meeting is now being recorded.
INCOSE Healthcare Working Group is one of several industry-focused working groups within INCOSE. Healthcare and biomedical applications are still a non-traditional industry for systems engineering, so the Healthcare Working Group was formed to bring together systems engineering practitioners and systems thinkers in order to share experiences and improve the overall state of systems engineering for healthcare and biomedical applications. We are also very interested in working with systems engineers from outside healthcare so that we can learn about the tools and techniques from the traditional systems engineering fields like defense, aerospace, and automotive, and gain experience in applying knowledge from those fields to the problems in healthcare. The Healthcare Working Group has a number of work streams pursuing various aspects of systems problems in the healthcare industry. We welcome all of you to contact one of the working group POCs in order to obtain more information. We always welcome new participants in our technical efforts, so if you drop me a note at the email address shown, I'd be happy to send you a short overview of our group and our activities. Each month I like to highlight some of the recent and upcoming events for INCOSE and the Healthcare Working Group. Today is the beginning of the annual INCOSE Great Lakes Regional Conference. The conference is being held in Indianapolis and features an extended technical track addressing integrative healthcare that will include, among other topics, care delivery, medical devices, informatics, and analytics. The Healthcare Working Group is just beginning its efforts to plan the next two significant INCOSE events. The first of these is the annual INCOSE International Workshop, to be held in January in Torrance, California. We welcome all of you to contact the POCs listed to provide your suggestions for activities at IW. And we are just starting to organize the planning committees for the working group's annual Healthcare Systems Engineering Conference. The 2019 conference will again feature both invited presentations and submitted presentations on medical device topics and lean systems engineering for medical devices. And in 2019, we hope to expand the scope of the conference to include topics addressing systems engineering for healthcare delivery. We would welcome any of you to participate in conference planning. We expect to release the call for papers in early January. I want to make you aware of a few INCOSE policy changes that will affect the Healthcare Working Group's communication process. INCOSE will soon be conforming to the new personal privacy rules established by the EU. Following these rules is mandatory for communications within INCOSE's European sector, and it is expected that similar rules will soon be established by the countries in the other sectors. The key outcome for the Healthcare Working Group is that we will cease using our Gmail mailing list. This mailing list included both INCOSE members and non-members. INCOSE members can sign up for the INCOSE Managed mailing list for the working group by logging into their INCOSE account, visiting their member profile, and making sure that healthcare is one of the committees they have selected. Non-members can stay apprised of Healthcare Working Group activities by joining our LinkedIn group. Webinars and other healthcare systems engineering activities will continue to be announced via LinkedIn. You can also visit our YouTube channel. We will be transitioning to posting webinars on that site as well. I also want to give you a quick heads up about our November webinar. Our November speaker will be Bijan Elahi, the Principal Educator for Project Performance International. Mr. Elahi is an award-winning educator in risk and safety management for medical devices, and he will be presenting his insights concerning the recent regulatory evolutions related to medical device risk management. The webinar will be held on November 14 at our normal time of noon Eastern Time. Webinar details will be emailed and posted to our LinkedIn site about 3 weeks in advance of the webinar. I'd like to quickly review our SOP for the webinar. We'll have roughly 45 minutes of presentation followed by Q&A. Your phone lines will be on mute during the presentation, so as questions occur to you, please type them into the chat box in the lower left of the Global Meet screen. At the end of the presentation, we'll address chat box questions in the order they were entered. Due to issues we've had with background noises and feedback, we will keep everyone on mute and will continue to accept questions through the chat box. So as the Q&A discussion proceeds, please continue to enter your questions into the chat box, and we'll get to as many of them as time allows. We will make the presentation available. A PDF copy of the slides will be posted to the Healthcare Working Group's public website. We try to keep the presentations from the past few webinars available for download from our public website. You can connect to that site via the INCOSE homepage. Presentation should be posted in a few days and will remain there for several months. Please note that the webinar is being recorded. Webinar recordings are currently stored in the members-only area of INCOSE Connect. Over the next few months, we will be transitioning to storing the recordings on our YouTube channel. And now I'd like to introduce our speaker, Professor Bo Oppenheim of Loyola Marymount University. Today, Bo will be sharing with us the insights he gained during a year-long study involving intensive interviews and surveys with 15 healthcare executives in Kaiser Permanente, Children's Hospital of LA, UCLA Health, Providence St. Joseph, VA, and others. The presentation will summarize the opportunities for healthcare improvement that systems engineering can and should address. Bo is a professor of systems engineering at Loyola Marymount University and serves as the director of the Healthcare Systems Engineering Master's Program at Loyola. This is one of the premier healthcare systems engineering programs in the nation. Loyola's Healthcare Systems Engineering Program was created in a close partnership with Kaiser Permanente. Professor Oppenheim is the author of 4 books and authored and co-authored chapters in 6 other books and has published over 30 journal papers. He was honored with 3 Shingo Awards, the INCOSE Product of the Year Award, and the INCOSE Fellowship. Bo, welcome to our webinar, and thank you for being willing to share your work and innovative ideas. If you'll give me just a minute to stop sharing my screen, then you can begin sharing yours and begin giving your presentation.
Thank you very much, Bob. Okay. Let's see if the sharing works.
Okay, I think I have stopped here.
Okay, share my screen. Can you see my screen?
Yes, I can. Yes, I can.
Okay, perfect. So we are ready to go. So Bob, again, thanks very much for the kind introduction. Good morning, good afternoon, everybody. This is the same presentation as the one I gave at the IS. At this time, it's been 6 years since I entered healthcare. Prior to that, I practiced regular systems engineering in defense industry. And so coming into this project, I already knew that there is a big gap in the understanding of what systems engineering can and cannot do to healthcare, to help healthcare. So I decided to do this project to approach the question more systematically. We can skip the glossary. So let's start with this big question. Is there a need for systems engineering in healthcare? Healthcare, as we know, is a $3 trillion segment of U.S. economy, by far the largest. It is troubled. It's troubled by ugly ideology, by politics, by avoidable death. There is 400,000 preventable deaths in the U.S. In healthcare. Poor outcomes, poor access, huge inefficiencies, financial abuses, fragmentation, cottage industry roots. Big problem is the burnout of providers, medical doctors and nurses. There's a huge shortage of nurses. So, of course, we have the islands of excellence in our healthcare system, but yet the problems are big. We recall that in 2014, the White House PCAST report called for systems engineers to come to the aid of healthcare. And as I mentioned, we've been confirming this big gap between the 2 domains. So this presentation, this study, is my contribution intended to provide a better understanding of the role of systems engineering. This chart is really profound to the understanding of our role. Namely, when we compare, the right column has the healthcare delivery project sizes, different parameters of project size. And in the middle column compares that to the defense industry. We see vast differences in size. So the number of full-time employees per project in healthcare is on the order of 2 to 3, sometimes 4, 5 for larger projects. We are used to thousands or tens of thousands in big defense projects. The part-time employees in healthcare measure several, a few. Typically, it would be a nurse from that department, a hospitalist from this department, an IT person. Typical schedule in healthcare projects lasts weeks to months. A one-year project is regarded as big, while in defense we are used to tens of years. Budgets, again, healthcare projects are typically measured on the order of tens of thousands to hundreds of thousands. That's very rare, very big. That compares to millions, hundreds of millions, billions in defense. Requirements. In healthcare, very often we are dealing with projects with only one requirement, or only a few. At the maximum, a few tens, 20, perhaps 30. That compares to hundreds to thousands of top-level requirements in weapons program. The complexity in healthcare, even though healthcare is hugely complex as the entire system, but when we think of individual projects, we are typically dealing with only a few unknown unknowns, or none. So in that sense, the complexity is small. In the weapons program, of course, we are dealing with huge, both technical and political complexities. Healthcare projects tend to be executed within a single clinic or a hospital or a central office of a large, perhaps medical organization, and then, when proven successful, they are disseminated to across the entire system. So this is very important to understand the different scales of the project. I adopted the following methodology to my project. It was based on a survey of, as Bob mentioned, 15 healthcare executives, and the survey was conducted face-to-face, and it had 3 parts. Number one, I asked them, what do you understand when you hear the word systems engineering? Secondly, and this was the main part of the survey, I asked them to rank the use and importance of the 20 systems engineering process steps, which I took from the Systems Engineering Handbook by Andy Sage in your institution. Number 3, I created some ideas for 14 potential large national level systems engineering programs, kind of like weapons programs, and I asked my interviewees if they would like to see such a program funded nationally. As I mentioned, I did it via face-to-face interviews lasting typically 60 to 90 minutes, whereby I would explain my question first and then ask for the rankings. Let me show you the list of the people I interviewed. So you probably, the names will not tell you much, but look at the titles, their positions. Assistant Directors of VA, Senior Vice President, Executive Vice President, Chief Quality Officer, and so on. So I believe that this sample really includes the top-level view of the healthcare industry on the questions we are discussing. So here are the results. First, what do you understand by systems engineering? Only one of the interviewees had a formal background in systems engineering. One other had some limited experience. Most executives had a good background in project management, the way the PMI defines project management. My findings were that the systems engineering process is poorly understood by those interviewees. Here are just 4 examples of what how they perceive systems engineering, that it's systems thinking, that it's a strategy, mindset, ability to look at issues systemically, that it means connecting the dots, that it means intentional design of projects to deliver reliable healthcare. So in the conceptual understanding, they have some idea, but in terms of the nitty-gritty, definitely not. Now the second part. I asked them to rank the use of a given systems engineering process step and to rank the importance. The scales are listed here. So 1 is the minimum ranking and 5 is the maximum ranking. And here we come. So now I have 20 slides, 1 per process step. The horizontal scale is simply the numbering of the healthcare professionals, but the names that I showed you earlier have been randomized. So you will not find the correlation there. The vertical scale represents the ranking. The real ranking starts from 1. So the 0 is simply the way the plots were made by Excel. The black bars represent the use, and the gray bars represent the importance. So I asked them, do you start your projects well? Do you start with really an excellent capture of what is needed, capture of the challenges or gaps or opportunities or whatever it is that makes you start this project? Do you really have a good understanding of that and it's unrushed so that you can proceed then properly through the project? And they said it's very important, 4.8, but no, we don't do it very well, so it's only 3.8. Next, I asked them if they use the project management, but I explained the systems engineering version of project management, which means good requirements, good risk management, analysis of alternatives, architecting solutions, and so on. They ranked the importance at 4.2, and they use 3.0. They do use project management, but it's focused primarily on schedule, budgets, and the management of resources. In other words, more of the PMI version. Systems thinking, they all agreed it's hugely important, and they admitted that they don't use it very much. They blamed the medical education, medical culture for it, which tends to be very myopic, and in medical schools they don't teach systems thinking much. Project value, the excellent capture of the value, the goals that addresses the need. In other words, I asked them, do you really conduct extensive conversations with stakeholders when you try to capture the value? Those are not yet the requirements. That's one step earlier. So they ranked the importance of it highly, 4.6, and the use is kind of 3.1. They admit they don't do a very good job of it. Development of use cases and scenarios. In other words, I told them, do you often have a situation where somebody in the room says, yeah, I know how to do it, and then they run with this idea? Or is there a culture of slowing down and saying, no, let's evaluate different possibilities, let's different alternatives, and let's judge them objectively, and so on. So they admitted that it's important, and they don't do it very often. 3.0 use, importance 4.4. Formulation of good requirements. There is the culture of requirement formulation is not present much in healthcare. The use is only 2.4. They do write what they want to do, but it's not written with the precision and the discipline to which we are used in healthcare. That each requirement must be crystal clear, unambiguous, verifiable in a binary way. So I had a lot of discussions with them at this point, and they regard it as important but not apparently as critical. They say that the way they do it is not terribly bad, except that they don't do it. The problem is not that they do it in a wrong way. The problem is that they don't do it much. Allocation of requirements, importance, 4.1, use only 2.9, and the reason is that they, again, deal with only a few requirements per project. They don't really need to do a formal allocation of requirements. The allocation takes the form of, hey, you, Jenny, you are the nurse, so you do this part, and you, John, you are from IT, so you do that part. So it's kind of informal, collegial, not formal at all. Selection of performance metrics, they regard it as hugely important. Yes, they do use metrics. They are forced to use metrics by a whole bunch of regulatory bodies. They don't do a terribly good job of it. The use is only 3.1, but they regard it as hugely important. Designing systems architecting, so using DODA view. So first they had no idea what I'm talking about. Then I showed them some examples of OV1, OV5, and SV1, and they said, yeah, that looks good. Yeah, we could use that. We do use graphics. We do show the connectivity between the different sources of information, sources of knowledge, but we don't do a very good job of it. We could use more of it. So use is 2.1, importance 4.3. Definitions of different candidates, measures of effectiveness of candidates, selection of best candidates, they regard it as very important. 4.7, they don't use much of it. 2.8. Modeling and simulation, it's increasingly important in healthcare. There is more and more good simulators on the market. They regard those as important, especially in the training phase. They don't use them much yet, but they intend to acquire them increasingly. Risk management, they regard it as important, 4.5. They don't do a very good job of it. It's only 2.6, and they admitted that they are very often surprised in projects by unanticipated risks. So they liked the systems engineering version of it. Quality management. This is something they do practice. Importance is 4.1. They do use it. The use is 4.1. So this is one area where we had a total convergence. Designing, optimizing, and building system elements. So when I explained that a system consists of subsystems or system elements, and those need to be designed, optimized, verified first before being integrated into the larger systems. They said, yeah, it's a good practice. It's probably important. We don't use it much. And the reason is that our projects are small, so we do it really more by intuitive approach, not a formal integration. And here comes the integration part. The integration is important, 4.7. It's not used much, 2.7 again. The primary reason here is the lack of coordination. You probably know that the biggest problem, absolutely the biggest problem in modern healthcare is fragmentation. Fragmentation across all exits, lack of coordination among providers, communicating via the very imperfect electronic health records, lack of fragmentation across the shifts, time shifts, when one provider leaves, another one comes in, fragmentation across departments. Again, medical knowledge is taught in a very, very silo way, myopic way. So here are big problems in healthcare, and they do want to integrate their activities better. They are working on it. They don't do a very good job. People die because of the fragmentation. And I believe that here is our biggest area, biggest opportunity as systems engineers. After all, what is systems engineering? It's a body of knowledge of how to integrate complex systems. So this chart is hugely important, presents a huge opportunity for us. Verification and validation, yes, they regard it as important, where the requirements are formally done, but they don't do formal handling of requirements, so the use is only 2.6. In other words, it's a little bit ambiguous. They liked this concept, but they are not sure if they'll adopt it much. Operationalization. This simply has to do with preparation of training materials, training of the stakeholders, dissemination of the knowledge from one clinic to other clinics or hospitals, monitoring of the progress and so on. So yes, they regard it as very important, and they practice it, not perfectly, but they make a good attempt here. Model-based. This is one of the most controversial areas. So they almost, as you can see, almost uniformly answered that they have no use for it. They don't use it. The importance is ranked very low. Again, the reason is that their projects are small. The number of requirements are small. The number of interfaces are small. So they see other much more urgent problems in healthcare than the use of model-based. Complex adaptive systems, it's an approach that challenges the simple linearity of cause and effect, looking at processes in a dynamic way with interactions, relationships. So theoretically, we would think that this would be very important in healthcare because of the human factors, but the replies were negative. The importance only 2.6, and they use 1.3, which means they hardly use it at all. Lean and Six Sigma. Lean now is a standard and probably the most popular, the most accepted technique in healthcare for process improvement. So yes, they regard it as very important, and yes, they practice it. They don't practice it successfully. They admitted that they have a lot of learning to do on how to do it properly, but they are making an attempt, and they regard it as important. I also asked the question, okay, what have I missed here? What other processes, tools, or systems engineering elements you would like to see? So they listed 4 groupings: human factors, leadership aspects, the cultural aspects, queuing theory, latency problems, late times, machine learning and AI, and data visualization. So of course we recognize those as very important, but they are outside of the traditional systems engineering domain. One person mentioned also the system of systems. So here is a summary. Here are the 20 systems engineering steps that I discussed. And in the columns, we have use rankings, importance rankings. Those are the averages, and the delta between the averages. And on the next slide, I have the same information presented graphically. So we see as a general conclusion that the gray bars far exceeds the black bars. Again, the gray mean importance and the black mean the use. So we conclude from this part of the survey that all systems engineering elements which I presented to them are regarded as important, with the exception of model-based and adaptive systems. The average importance was 4 out of 5 or higher. The use was much less. This confirms the need for systems engineering processes in healthcare. In other words, after the interview, they all admitted it would be wonderful to have this knowledge and this practice in our projects. Presently, systems engineering process is poorly practiced. So again, the delta between the use and importance was between 0.9 and 2.2. That's a significant one. From part 1, we already knew that they have a poor understanding of systems engineering. So these results provide a solid argument for hiring systems engineers in healthcare and also for training the present healthcare employees in systems engineering. But we as systems engineers need to keep in mind that the emphasis in healthcare is vastly different than in defense industry. I use the word defense, but I also mean infrastructure. That namely the budget, schedules, and main loading of healthcare projects are several orders of magnitude smaller than in defense. The number of top-level requirements is very small, only a few to a few tens maximum. The projects are typically executed in one organization, like a clinic or hospital, and then, if successful, operationalized. So they have none of that nonsense that we have in weapons industry of dealing with vendors in all 50 states for political reasons. And therefore, I believe that we systems engineers must mentally drop the quote-unquote weapons mentality and humbly adopt the healthcare mentality of working in small, very patient-centric projects. All right, so at this point we know that the healthcare delivery projects tend to be small, but then I asked, but are there any potential large weapon-size type national level programs in healthcare that we systems engineers could become involved in or even lead? Those projects would be national in scale, not tied to any healthcare institution, or perhaps would be managed by a consortium of several large healthcare institutions. They would benefit all healthcare institutions and the nation simultaneously. They would create public knowledge. They would be similar, hopefully, in scale to national weapons programs. They would be led by systems engineering professionals. They would have to be funded by national bodies such as NSF or NIH or a consortium. And with this kind of mental attitude, I created a list of 14 projects which are listed here, and they are listed in the diminishing importance order. The black lines represent graphically the scale of importance, again from 0 to 5, actually from 1 to 5, and the last column of numbers represents the numerical rankings. So very quickly, let me list the top rankers. Number 1, defragmentation of healthcare elements, the integration of patients, providers, electronic health records, and the IT system and processes and devices. They regard it as hugely important. They suffer because of the lack of it. The system is fragmented. People die. People are harmed by it. So I think this is our big national opportunity for a large project. Next one is similar but focused only on the healthcare IT system. In other words, the development of a next generation integrated transferable healthcare IT system. This ranked 4.2, and the following, 5 projects again rank 4.2, and they are the transfer of presently in-clinic activities to patient homes or the mobile devices using internet. It's only the beginning of this activity. They see a huge potential in it. Increasing potential health capabilities and effectiveness. The population health refers to the activity which addresses the needs of large groups of patients, such as diabetic patients, sending them messages, reminders, and so on. Next one is development of architectural systems of clinics, of clinic buildings, of hospital buildings for better execution, delivery of healthcare, and this has to do with being conducive to teaming. They regard teaming as increasingly important, so they want the architecture of clinics and hospitals to be conducive to teaming, to people working together, seeing each other, talking to each other, not writing interface control documents the way we do it, but basically speaking to one another. So a doctor telling the nurse, see that patient in room 7, go and do this and that type of interactions. Next one is Lean. Again, they do practice Lean. My question here, asked them if they would like to see a national development of a national knowledge of Lean in healthcare, because presently it's done as a cottage industry. You know, they hire somebody who thinks he or she knows Lean, and that person does a few projects, and they are typically not terribly successful. So I asked them, would you like to see a national development of this knowledge that would be shared across all clinics, hospitals, EDs, ORs, labs, pharmacies, and so on? And next one is the development of mobile on-patient or in-patient devices transmitting data to EHR. And let me skip the others because they rank lower on importance. So I also asked, is there anything else that you would like to see in that list? And yes, they proposed two projects. One would be the National Collection or Library of High-Impact Systems Engineering Projects in Healthcare. In other words, they want to learn more about systems engineering successes, but they don't see them yet. And the measures of real quality in healthcare, the development of metrics, results, and so on. Again, they are now governed by a huge number of regulations, all of them intending to assure high quality, but they say that those metrics are very imperfect and sometimes even mutually conflicting, extremely bureaucratic, very costly. So they say it would be nice to develop a national set of such metrics. All right, let me summarize the entire project. So yes, several large-scale, national-level healthcare programs have been ranked high, and I discussed them. They are listed here in black. But the bulk of the healthcare projects are small on the scale of a clinic or a hospital. And even the projects undertaken to serve large medical institutions, such as Kaiser Permanente, are first executed or piloted on a small scale and then, if successful, operationalized, disseminated across the institution. I believe that I discovered that the systems engineering knowledge is needed in almost all healthcare projects, even small ones. I shouldn't use the word I discovered. I confirmed. I mean, we knew that coming into this project. We knew it very well that it's needed. So I confirmed quantitatively. That knowledge is still lacking. So I believe that healthcare systems engineering academic programs provide, we have a few of them in the nation, provide excellent education in healthcare-specific systems engineering, and that medical institutions should hire such graduates or pay employees to obtain master's degrees in healthcare, that it would benefit the industry, it would benefit the nation, and most importantly, it would benefit the patients. So thank you so much. In the appendix, I have the individual rankings for ideas of those large projects that I already discussed, but it will be in the handout that Bob will distribute. But basically, I think we can proceed to the discussion now. So thank you very much for your attention, and I'll be delighted to take your questions. Let's see.
Thank you very much, Bo. There's been a rather lively discussion going on in the chat box, and I'm trying to figure out how the easiest way to start summarizing it. The early phases of this discussion focused on the observation you made that process 15 about integration is seen as important but is not well practiced.
Yes.
And you mentioned fragmentation as being one of the key problems hindering healthcare. And I guess those two seem very much like they're linked, that there's a little bit of a chicken and the egg, that if everything is fragmented and siloed, then it's hard to get people to understand integration. And then vice versa, if you don't know anything about integration, you tend not to look for the connections.
Let me maybe, with your kind permission, Bob, let me address those before we move on. So yes, so indeed they do regard integration as important. They regard fragmentation as the biggest evil in modern healthcare. They don't have a systems integrator, a formal position of a systems integrator. It's basically the person who is the project manager, plays that role, but very often the emphasis in getting the project done on budget and on schedule as opposed to doing a proper integration. So I don't think they do a very good job there. I read that the Mayo Clinic... I'm sorry, Bob, go ahead. Maybe you should...
No, I think you're answering the question that I see inside the chat box.
Let me address them one by one. The Mayo Clinic has used model-based. Yes, I note so. None of my interviewees use model-based, and some who really understand model-based were negative. We had, you probably know that we had one of the interviewees attend our healthcare working group meetings where model-based was discussed at length, and he was less than enthusiastic about it. I don't know the answer to that, but the integration and integrator seems like a good topic to explore during the Q&A. So that's what we are doing, hopefully.
Yes, that's what we're doing. And I guess there's a little bit more down here in which people are trying to explore. You know, integration certainly should be a tremendous strength of any good systems engineer. Absolutely. And so how do we start getting systems engineers into the mix so that can begin occurring? I mean, given that their systems engineering isn't well represented in healthcare and its projects, how do we insert more engineers, particularly since a lot of them may well be trained in systems engineering of other stuff?
Let me comment on this comment. Healthcare tends to have small projects because they haven't had the discipline to address things from a system. During your interviews, did the interviewees seem open to larger scale projects? Yes, we did discuss that, but the premise is wrong in that question. They see problems as basically small size, difficult, but small size. In other words, they don't see any benefit in looking at the question of faster discharge, for example, of patients from the hospital, as to be seen by all hospitals in the system. They need data from all hospitals to see how well they are doing, but then they attack the problem on a small scale, and they want to see how well it performs. Problems are generic. They really are the same at Kaiser Permanente Sunset and Kaiser Permanente West LA. So other than to get the starting data, how well or how poorly they do, I don't think they benefit from having a huge system to address. So it's not the lack of discipline. It's not the lack of enthusiasm for the large projects. It's simply that they believe, and I agree with them. I've been working with them for 6 years now on projects. I've done hundreds of them. Some I manage personally, and some I manage my students' projects. I think that the small-scale approach works better. There are some national level challenges, and I listed them, and I explained to you folks what they are. And yes, they agree those would be nice, but they are above the level of the institution. They are national in scope, but within the institution, they prefer, and I think rightly, to address problems as small projects. They don't have the budgets. They don't have the billions of dollars that the defense industry has to approach those gigantic problems within the single institution. It's simply not doable with the present management.
Well, I certainly appreciate the issue of that the finances and then the other timelines that go on within healthcare, which is very much focused on dealing with patients who need treatment right now. One of the questions that occurs to me, though, is it seems to me that with small projects, integration within the project would seem to be much less important than integration of the product into the bigger picture.
Yes.
So, I mean, I've identified a problem that, this class of infusion pump has a problem because, it's so hard to put the data in there, so we're going to work on, getting better data to program the pump and a better user interface. And so there's integration that happens within that pump, but then there's also integration that says, well, okay, where is this data going to come from? Is it going to come from the pharmacy? And, looking at everything outside that pump in addition to what's inside it, that's the stronger need for integration, and that would address the issue of fragmentation.
You're absolutely right that aspect is needed, it's missing. But I don't think they would benefit, answering that question, I don't think they would benefit by having $1 billion program across all hospitals within Kaiser Permanente. It's still a problem.
I agree with you. I'm just thinking in terms of exploring your thesis that, yes, there's a role for the systems engineer. If you could get a systems engineer involved in these small projects, even on a part-time basis, to look at this much broader scope aspect and say, well, okay, before you glue this thing together, you need to put some connections in to tie into that, and you need to go talk to these people about where certain things are going to come from.
And that's exactly, that's what my project confirmed very strongly. One of my main conclusions is exactly that each project conducted in healthcare, regardless of how small or how big, could benefit from the presence of a systems engineer. And they admitted it. They liked what I was telling them about systems engineering. They liked the individual process steps. Most of the difference between the use and the importance was fairly high. So absolutely. So I think there is room for systems engineering. Only we need to be a little bit humble as systems engineers when we come to them, and we need to lose that this grandiose approach of large, complex programs with hundreds or thousands of requirements. That's not what they need. That's not what they expect.
We just got another question in. Says everyone agrees that healthcare needs systems engineering. I think they want it if it's profitable. How much systems engineering should we do to have a positive return on investment? And I guess that's a broader scope issue of just that whole ROI problem. How do you show that?
I don't have any hard data on it, on the return on investment, like the famous study by our colleague at INCOSE. But informal, anecdotal understanding is that they would be happy to involve systems engineers. And in fact, now we are graduating the fourth crop of students in healthcare systems engineering, and all of them found work, and all of them have found meaningful work, and all of them are involved in projects. So I have that level of confirmation that yes, systems engineers are needed and are useful, but they need to be healthcare systems engineers. They cannot come from the F-35 program and expect to use the same approaches when they come to work for a clinic.
Okay, I'm very curious. Have you had anybody with a clinical engineering background go through your program?
Yes, absolutely. Absolutely. We had medical doctors, we had nurses, we had clinical engineers, we have had science people, absolutely so. And all of them like it. We are yet to have a student who says it's useless. I wasted my tuition money. So they go to work for industry, and they regard this knowledge as good knowledge, needed knowledge, practical knowledge.
Okay, it's extremely encouraging, and very pointed in terms of what it takes to make the transition from being a general purpose systems engineer to being a healthcare systems engineer. That you need to get focused on the specific problems and terminology and the kinds of interactions, things like that.
There is one question here I see. Let me read it. At an HHS tabletop exercise last week, which simulated a pandemic and cyber attack, the leaning of the overall supply chain was noted as a significant risk for pandemic response. Yeah, it's a good comment. I'm not sure how it relates to our discussion. Masks, syringes, ventilators, pharmaceuticals are all in limited stock. Back to the manufacturer. Okay, let me skip that. Everyone agrees that healthcare needs systems engineering, but I think they want it if it is profitable. How much systems engineering should we do to have positive ROI? So I believe I answered already.
Yes, you did. Yes, you did. I think on the issue with the HHS tabletop is that you had pointed out that lean was one of the techniques that's been embraced within healthcare, and that they seem to be they like the outcomes, and they're working hard to practice it. And when you look at it, HHS tabletop, of course, they're looking much bigger picture. They're looking beyond just an individual hospital, where most lean.
Yeah, I think this problem belongs more to the public health body of knowledge rather than the healthcare delivery at the level of hospitals or clinics. Of course, there is a huge number of problems which are national in scope, which deal with public health, public safety, vaccination, all of those things, communicable diseases, but they are managed nationally now. I don't know if HHS has systems engineers on the staff or not. They definitely should have some. Maybe among those, that list of the national level projects, maybe I should have more of those. I didn't, and it's my fault.
Well, there is a comment down at the very end that public health is a huge system of systems problem.
Right. Yeah.
And so that echoes what you're saying about if they don't have systems engineers, they really should have them.
They should,
because
have, yeah. I dealt more with at the level of the healthcare institutions, delivery institutions, and that's where the vast majority of activities happen. If we can fix that part, folks, if we can fix how the hospitals and clinics operate, we would be hugely successful, and there is plenty of room for us to help them, and they do need that help, and they know it, and they admit it. So we should stay in touch with the healthcare professionals. We should propose solutions to them, but we must keep in mind their limitations.
Okay, there's been another comment that says metrics are what is missing to objectively show the value of systems engineering. Now in your presentation, you had said that metrics overall are a challenge within the healthcare industry.
Well, in a way, let me take some difference to this comment. I believe that that survey was a contribution to show objectively the value of systems engineering. I mean, each slide represented a measure of the need of the given systems engineering process. So together, they do measure the value of systems engineering, and I think we confirmed the value of systems engineering in this survey.
Oh yeah. No, I think what the comment is referring to is on a project by project basis. That
I see.
These 5 projects had a systems engineer. Look at them; they're way more successful than those 4 projects that didn't have a systems engineer.
Right.
And how do we?
In practice, the anecdotal knowledge is probably handling that, because after a while they will discover very soon, and very convincingly that the projects which had a systems engineer on the staff did much better than others. So they all simply expand that practice, I think.
Yeah, and that goes back to you had a slide about other suggestions made by the interviewees, and one of them was trying to get the case studies together of good systems engineering projects,
yes, right.
healthcare.
Right.
And I know the working group has been trying for a while to organize an effort like that, but it's pretty challenging to get that information pulled together.
Perhaps one solution to that would be to ask the universities that have programs such as mine to share at least some information about the student projects. All of our students, for example, do projects actually in healthcare institutions. That's a requirement. So we alone have contributed probably about 50, 60 projects.
Okay, that sounds like an extremely rich to explore, because you have people whose job is to do a project and then write it up and highlight where systems engineering played, versus if you actually go and find a clinical engineer who's full-time employed, and he might be very willing to share information with you, but finding the time to write it all up, well, that's difficult. So yes,
right.
Yes, the projects from the healthcare systems engineering program sounds like a rich area for gathering that data.
Let's talk about it in our working group, absolutely.
Okay. Let's see, we're running up towards the end of our hour. I guess we have time for one more question.
Maybe you need to unmute the folks, Bob.
Well, I've been asking everyone to put their questions in through the chat box, because unmuting people is, we so often get feedback. But we've already had a very lively discussion. Kind of scrolling through, I don't see anything really that we've missed. Okay, so I'm going to go ahead and wrap things up. Bo, thank you again for
thank you
for sharing your work, and my thanks to everyone out there in webinar land for participating and for your good comments and questions. As I said at the beginning, we will be posting the slides on the Healthcare Working Group's public website, and you can get to that by first going to the main INCOSE website, incose.org, and then there's a little icon for Find Your Community, and that will take you off into the part where you'll find a link to all of the working groups, and just pick the healthcare one. We should have that up within a few days. So thank you again, and we'll sign out at this point.
Thank you very much, Bob.